Hi, Dr. Stone. Hi, Dr. Yancy. Patients often ask why research trial focuses on women, African American, and Latino participants. Please explain why these groups have been historically underrepresented in cardiovascular research and how the lack of representation can affect how accurately we understand heart disease and treatment outcomes.
Well, thank you. Maybe I'll start and then Dr. Yancy will complete the answer. I think it's actually a complicated question. We'd like to think that the randomized trials that we perform are representative. That is, first, they are reflective of the makeup of the United States or whatever geography in which we're enrolling patients. And that two, they include higher risk patients as well as lower risk patients. And people are different. People have different biologic factors, they have different makeups, they have different risk factors, they have different socioeconomic issues, and all of that factors into the response to different types of medical therapies, whether it's drug therapy or procedures, such as stent procedures or heart bypass surgeries. And most of the trials, for a variety of reasons, have enrolled mostly white men. Probably about 1 in 5 patients, maybe slightly more, have been women. And of course, women make up slightly more than 50% of the population. Now, when you look at patients with coronary disease, there are more men than women, but still, women have been relatively underrepresented in our prior studies of stents and bypass surgery. And particularly challenging has been to enroll patients of color. And it's in that regard, it's particularly important that we do understand the outcomes of therapies in Black and Hispanic patients in particular, because they are the patient groups who tend to do worse with both stent treatment and with bypass surgery. And again, because all patients are different, what works in a white man may not work in a white woman. What works in a white person may not work in a Black or Hispanic person, or there may be slight differences. And it's very important that we develop the right kind of evidence to inform patients and physicians to be able to choose the best therapies that work for all types of people. So, Dr. Yancy, let me get your perspectives on this.
So, Dr. Stone, let me fully support and amplify your response to this because it's such an appropriate question. But let me also add a couple of additional caveats. The first one being is that we have no reason to believe that biologically the populations differ. We have every reason to believe that the circumstances, particularly the social circumstances, and their interaction between society and health is invariance. And there's enough similarity in how that experience develops and evolves with each group that it's so pertinent to have this question answered contextually, meaning for women, for underrepresented groups. But for the patient that raises this question, there's another response that I think is so important. Why not? There's nothing about the disease processes that overlook or skip or don't engage women and underrepresented groups. Heart disease is ubiquitous. There is no group that is spared the burden of heart disease. Shouldn't we know how best to treat heart disease in every group? So the real question looking forward is why not? Wouldn't all of us wish to know that if there was a recommendation for an invasive procedure, one potential with complications, to treat our specific condition, that somebody somewhere, like the recharge investigators, answered that question. And so there's less uncertainty than there's been up until now. So endorsing everything you said, Dr. Stone, but adding to that, we're not exploring biological differences, maybe some nuances, male versus female. What we're exploring are social circumstances. And what we're finally doing is that we're taking an about time approach. Now is finally the right time to answer this question so we know exactly how to treat anyone and everyone who has heart disease.
Couldn't agree with you more. Thank you.